So it is my privilege to be able to introduce our keynote speaker for lunch today, David Goldhill. David is the president, CEO of the Game Show Network, but he has taken a keen interest in healthcare and has written a book which all of you, I think, have taken a copy of today. And it was referenced in the discussion this morning by Chad Savage as a must-read book for those of you who are interested in direct primary care. And David had a very personal story about healthcare in his family, and I'm not going to steal his thunder, but this is what I think got him thinking about this whole issue, and now this is something he's quite passionate about, and it's really a delightful talk and something that's revealing and quite interesting. So without any further ado, please let's have a round of applause for our speaker, David Goldhill.
Thank you. Thank you so much for having me here. I probably should start with, I guess what in the universities today they call a trigger warning. I am not going to talk about either health or care with the typical reverence that one does. I'm an outsider, and much of what I talk about is going to treat healthcare and look at healthcare as an industry, because it is, in fact, America's largest industry. And as you'll hear, my suspicion is that the major problems with healthcare are not about healthcare or health or care, but industrial. And that when you take an industrial perspective on healthcare, you get a very different perspective than insiders and most policymakers have. 1965 is a very important year in American healthcare. It's the year that Medicare and Medicaid were enacted. It's also a very important year in computing. It happens to be the year that the first commercial mini computer was introduced to the market. It's the PDP-8, and it was sold by a company that no longer exists called DEC, and it sold for $19,000. And it was really the first computer product that was designed for somebody other than the mainframe customer, the NASA's, the IRS's, the Defense Department. This was designed for a company to do its payroll. It was an extraordinary thought that the most complicated product in the history of mankind could be used without a computer science PhD. At $19,000, the PDP-8 was not a consumer product. In fact, to give you some perspective, the average spending on healthcare in the United States that year was $225 a person. So the PDP-8 was about 80 times what we spent on healthcare in 1965. Fast forward today, and I think many of you already know where this is going. About 2 billion of us carry a smartphone. Most of you are desperate to get on yours now and wondering how long into this talk it will be polite to do so. I feel the same way. These things are a crucial part of our lives. They are extraordinarily accessible. My mother, who I don't know how old my mother is, I know she's older than me though, uses one as an integral part of her life. Somehow, in the 50 some odd years since the PDP-8, the computer industry figured out how to take the most complicated product ever invented by humans and make it so accessible that grandmas carry one. And not just a PDP-8, something far more powerful and far more useful, measured every possible way. 50 years, 2.5 generations. And you know the punchline. Somehow we managed to take the most personal and important product, healthcare, and do the opposite. Make it less accessible, more complex, and insanely more expensive. So the average smartphone sold around the world went for $250 last year. the price of American healthcare is now up close to $10,000 per person per year. So in 2.5 generations, computers went from being 80 times as expensive as healthcare to 1/40th. Here's the punchline. If you Google why healthcare is so expensive, by far, overwhelmingly, the most typical answer is technology. Does anyone really believe that? I'm going to make a completely different argument here. I'm going to make the argument that starting in 1965, computer manufacturers took on the most difficult task imaginable, which is how could they get a powerful computer in the hands of grandmothers? Healthcare, starting in 1965 with Medicare and Medicaid, perfected something very different, which is making the customer of the healthcare industry not individual patients, not my mom, but big bureaucracies. Health insurers, government, Medicare, the VA, state Medicaid agencies. In almost every case, there is a different customer than us for providers. And I realize I'm talking to mostly physicians here. The us is a rhetorical one. Now, if you're smart and you analyze healthcare, you undoubtedly have your favorite reason for why healthcare is so expensive in the US. And I'm here to tell you that everything you have to say is right and wrong at the same time. We spend about $3 trillion a year on healthcare. A lot of people think end-of-life care explains why US healthcare is so expensive. We spend so much at the end of a customer's life. So if Medicare stopped spending a penny on anybody within the last year of their life, we'd have to have some foreknowledge, but assume we could do that, we'd save $170 billion, 5.5 cents on the buck. A lot of people think it's advanced care, particularly cancer care and oncology, which we spend far more on than anyone else. So let's not do any of it. We save $150 billion, 5 cents of every dollar. A lot of people, I know you find this hard to believe, think physician pay is the problem. How many people agree with that? It's usually a little larger than the share of the audience, but so let's pay physicians nothing. Just work with me here. We'd save $210 billion, 7 cents. Increasingly, people think the problem is our expensive prescription drugs, and we sure pay more for prescription drugs than anyone else. So let's pay nothing, $300 billion. Now, for those of you who are good at statistics, you realize that, in fact, these are not additive. There's a lot of prescription drugs in cancer care. There's a lot of physician pay in end of life. But if we pretended they were additive and you eliminated them, America would spend more per capita on healthcare than any country in the world. The answer is all of the above. Everything about American healthcare, every single thing is more expensive. And so when someone comes and says, I've got a great idea, let's eliminate this, or let's reduce this, or let's modify that, it doesn't really work, even if it seems to work. We can cut any of these, reduce any of these, whatever the great ideas are. This money will appear somewhere else, and I'll show you why. It's because of Becky. When I wrote that extraordinary book you have in front of you, one of the first things I did is I looked at what a starting out employee for us would pay over her lifetime into the healthcare system. Because the most important argument for having intermediaries is that it protects us and saves us money. It's called insurance. It protects us against those terrible situations where we have a health crisis we can't afford. Well, it's fiction. And if you look at Becky, you'll understand why it's fiction. If you figure out everything that Becky's going to contribute into the healthcare system over her life, over her career, and then beyond. So I mean everything. Her share of premiums, our share of premiums, comes out of her pay after all. If we didn't pay for health insurance, we could pay her more. Every economist agrees with that. Her Medicaid taxes, the share of her federal taxes that go into federal health care programs, what she'll pay in Medicare premiums, what she'll pay in deductibles. If the cost of health care had risen by 0 when I did this in 2013, Becky would put $1.2 million in the healthcare system over her lifetime. If it rose by what the administration predicted when it proposed the Affordable Care Act for 10 years and then 0 thereafter, the number is $1.9 million. If Becky has a working spouse, it's $2.5 million. Now, I made a couple of assumptions here that are important. I assume that Becky doesn't get rich, that she continues to have a middle-class income for her entire life. I also had her husband leave her at Medicare at 65 just to make the calculations easier. And I assumed that no one in her family ever got sick, meaningfully sick, more than a broken bone here or there. So obviously, in any of those cases, the number would have been much higher. Why doesn't this work? Because the way insurance works is it protects us against something rare happening, our house burning down. If all of our homes are going to burn down, insurance doesn't work. It doesn't share the risk. It actually just makes the risk more expensive. Because now, not only are we pooling all of our homes burning down, we've got to bear all of the administrative cost that goes along with it. In healthcare, we've done something different. Not only do we bear the administrative cost of insurance, we've turned the insurer, not us, into the customer. And the insurer as a customer has different incentives than we do. There's a lot of people who weirdly believe that insurers still have an incentive to keep healthcare costs down. They appear not to know how insurers make money. And I'm glad you think that's funny, because it's incredible, isn't it, that we're 50, almost 60 years into insurance being the primary form of private care, and a meaningful number of our policymakers still believing it. How many years are they going to have to fail at this task before we stop hearing politicians relying on insurers to save money in the healthcare system? It really is extraordinary. You know, in my book, I talk a lot about incentives, because I actually don't believe in villains. I've had an enormous opportunity to meet lots of people in healthcare, and what strikes me is how many of them, no matter what they do, are motivated by a genuine desire to help people, to do good things, to find cures, to nurse the sick, even to make it all more efficient and seamless. We don't fail in healthcare because people in healthcare are bad. The drug companies aren't uniquely bad. Doctors are not uniquely bad. I know that's a minority view here. But we know that the way we debate healthcare is about who's the villain. Is it the insurer? Is it the hospital? Is it the There are no villains. What there are bad incentives. When I talk about incentives, people misunderstand what I mean. Doesn't everybody have an incentive for higher prices, to cut corners, lower quality, less efficiency? So maybe it's better explained in terms of disincentives. What healthcare is missing is the proper disincentives. When I was a teenager, I used to take my grandmother to the local supermarket, where she would return the quart of milk she had bought 3 months before because it had gone bad. And I learned what I think is the most important lesson in consumerism through those experiences, because my grandmother lived in a neighborhood with a lot of fairly independent senior citizens. And so you walk into that supermarket holding a quart of milk that's gone bad, undoubtedly the supermarket's fault. That supermarket's filled with senior citizens. So the reason the store manager always, and I mean always, with that argument says, yes, ma'am, let me get you a new carton. I think she paid for only 1 carton of milk the last 20 years of her life. But the reason he did is because the disincentive to have an argument with a little old lady in a supermarket full of little old ladies is enormous. I would love to raise our prices. I'm incented to raise our prices, but I'm also disincented to raise our prices because I'll lose customers. I'd like to spend less time making our stuff good. I'd like to make it cheaper. That's my incentive. But I'm disincented to do so because I'll lose viewers, I'll lose players. In healthcare, how many players, how many parts of the healthcare environment lose profit for any of the normal reasons we do in the rest of the economy? Very few. And that, not evil, is the fundamental problem. I want to first, because this comes up all the time, I want to, there's a piece of conventional wisdom that drives me nuts, so I'm going to get it off my chest. If you go to a typical healthcare conference and you want everybody to nod, you'll say something like, you know, those guys who talk about building a consumer economy in healthcare ignore that in any given year, almost all healthcare is used by just a few people. 10% of the population accounts for, 10 years ago it was 85%. It now looks like it's down to about 70% of all healthcare spending. So whatever these people talk about, you know, having consumers or real economy doesn't apply to healthcare, because healthcare is about this. And that's why we need insurance, because we don't know when it's our turn. But that's the key point. Healthcare, in fact, in that sense, resembles almost every expensive good and service. Almost all of us buy cars over the course of our lifetime. Many of us buy several. In any given year, 100% of the cars is bought by 10% of the population. 100% of college education is bought by 10% of the population. 100% of weddings, 100% of divorces, 100% of refrigerators, 100% of any expensive good and service, universally used, in any given year is bought by a small amount of us. What's changed about healthcare, and by the way, so much of the conventional wisdom hasn't been examined in such a long time, is that healthcare now resembles these other things in the sense that we may not choose our year, but almost all of us are now going to have at least 1 year in that 10%. So the question is no longer like homes and fires. It's about like these other things, which is how do we transfer money over our lifetime to when we're going to need it in healthcare? The system we've chosen is the most expensive, complex, administratively burdensome way of doing that. And only when we really step back from these eternal discussions we've had in healthcare and think about it more broadly, do we realize getting money from our past self or our future self to our current self through an insurance system that adds all of this administrative cost and all of this distortion has been a disaster. Again, when you look at Becky, you realize you may not know you're paying for it. You're paying for it, every single one of us. There's a lot of, see, I told you almost everyone had a smartphone. There's a lot of distortion that comes about from an insurance system. The biggest distortion is probably in price. When my father had the episode, and I think many of you know, had a hospital-acquired infection that killed him, we got this bill on the left from Medicare. The price of killing him was $636,687.75. My mother's share was $992. Now, any of you who've been in any business know that bills are very important. They communicate something very important. And what this communicates is, you got a great deal for killing your husband. Only $992,000. That's a massive discount off of list price. So I said to myself, well, what if Dad had been king of Saudi Arabia? Now, he would have been the first Jewish king of Saudi Arabia, but nevertheless, it's a good thought experiment. So let's say we rented him a suite at the Four Seasons Hotel down the street. And let's say we leased all the equipment you would have in a hospital room. We gave him a full hour a day with a physician, which about 55 minutes more than I think he had. We gave him round-the-clock nursing. And two real pluses, the food at the Four Seasons is significantly better, and amazingly enough, cable TV is free at the Four Seasons. So the most I could spend with Dad as King of Saudi Arabia was $155,000. How did we get to $636,000? Well, of course we didn't. It's monopoly money. But it's monopoly money designed to let you all believe you're not Becky. Anybody who thinks they saved $600,000 here is someone who's going to put $2 million in the healthcare system over their lifetime. All of you. You know, one of the arguments for health insurance is that we're unsophisticated as consumers, and only insurers can drive the level of service that we need. So when my 11-year-old son carelessly burst his appendix, I, being his father, thought discipline was most appropriate. You really can't encourage kids to do this, particularly in our culture of entitlement. But his mother thought we should take him to the hospital, and they performed an emergency appendectomy. We, of course, got the letter from insurers you get whenever you do anything in the healthcare system, which is their esteemed physician has determined, I certainly hope he's not here today, has determined that it wasn't clear this was necessary. And in fairness, had he been a pet, I understand that putting him down would have been considered humane. His mother's very attached to him, though, and I'm glad we went for the other option. But does anybody who really believes that insurers and Medicare are driving a consumer-friendly economy, has anyone ever been to a doctor who believes that? Been to a hospital? Been to a clinic? One of the things that's most confusing about healthcare to people is prices. So the big argument for Medicare as it grows ever bigger and bigger is it pays low prices. Now, the amount of excess care in Medicare is sometimes beyond belief to anybody who looks at it from the outside. There was this incredible study done in Lancet which looked at every death, every Medicare death one year, and found that 1 out of every 3 Medicare patients who died that year had had surgery that year. 1 out of every 5 90-year-olds had had surgery in the year of their death. I'm not going to play doctor, but I don't think that needs much commentary. 40% of seniors take 5 or more prescription drugs. 40% of them are taking drugs counterindicated. The number was 20%. The latest estimate's higher. 14% of hospital admissions of seniors involve an adverse event. And the last time this was fully looked at by Medicare, although it does look like the numbers are getting better, frankly, the death rate from those errors exceeded the combat death rate in Iraq. And then we have things like spinal fusions and all the rest, where Medicare will publish a report saying you should rarely get them, and after the report, you see massive increases in the number performed. The Medicare trade is very simple. We pay very low prices, so the politicians think we're getting a good deal, and we make no effort to be a real customer of the healthcare system in any meaningful sense in terms of driving quality, appropriateness, or safety. I want to talk about my dry cleaning bill. When I started working in New York City, and part of the lesson here is do not do your dry cleaning in New York City. You know, you used to bring in your shirts at the end of the week, and they'd give you a handwritten thing, 5 shirts, and you'd pick it up and you'd get 4. And they said, well, we meant to write 4, you delivered 4. And then they got these sort of fancier looking cash registers that printed out something that said 5 shirts. And when you got 4, they said, well, we misinput the shirts. Fast forward, laundry services in New York City scan your shirt and tell you exactly what shirt it is, where it's from, what it looks like. It makes it harder for them to say, we lost the shirt, because you know exactly what shirt it is. Why did they do that? Wasn't that worse for them? Well, they did that for the reason everybody does things in the private sector, because the guy across the street did it. And if you don't do it, you lose business to the guy across the street. So even though you now actually have to pay when you lose a shirt, it's the only way to stay in business. This is actually how technology and information technology has advanced in every single industry. Trial and error, competition, figuring out what works, customer facing. Right? Efficiency isn't a goal, it's a journey. It's a competitive journey. These are the meaningful use rules. I'm not sure it's an accurate representation. I took a little bit of liberties, but I think roughly if you stack them in a piece of papers, it looks something like this. These are the instructions for an iPad. As any of you with a 4-year-old knows, there are no instructions to an iPad, and you don't need one. So in other words, what we've done in IT and healthcare has been the opposite of everything else in our economy. And here's something very interesting about it. Many of you may remember this famous RAND study that said, boy, if we had electronic health records, we'd save $80 billion a year, and it would only cost $40 billion to get the whole industry geared up. So the Obama administration said, well, let's spend the $40 billion. Sounds like a great return. 200% return, how could you not do that? Of course, you can't just spend $40 billion, you need a lot of rules telling people how to use it. And I think those of you who are on the front lines of this don't need me to complete that sentence. But here's what's interesting. The RAND study was impossible on its face. Because at the time of the RAND study, you got about 2 or 3% in the bank. So if there was a 200% investment opportunity out there, why wasn't it made? Most private equity firms are looking at mid-teens returns. 200% every year? They should have known, if they stepped outside of healthcare, that something was wrong with their analysis. And here's what's wrong. There is no question that electronic health records and intelligent use of information technology that is customer-driven and friendly would massively drive efficiency in healthcare. The reason it hasn't happened is no one can capture the savings. It's the wrong customer. And most of healthcare is still on a cost-plus basis. And that's it. $40 billion for what was then $2.5 trillion industry would have been the least amount of money on a per revenue basis that any industry had to spend to go to electronic records. Believe me, my dry cleaner spent a far greater share of revenue to get there. And yet it didn't happen organically. And one of the things I try to encourage people to think about is the reason things don't happen organically that should is more important than running around saying, this should have happened. How do we measure value in healthcare? Well, let's start with this one. Which is more expensive, an $8,500 Ferrari or a $12,815 Nissan Versa? Most of you suspect this is a trick question. So the $8,500 Ferrari is obviously more expensive because it is one of the most expensive car models made. I mean model cars. It doesn't work. It has no engine. It's decoration. And it's one of the most expensive car decorations anyone could buy. It's bigger than the size shown there, but not a lot. The $12,815 Nissan Versa, at least at the time I did this slide, was the lowest priced actual working new car in the United States. So we have a whole economy designed to figure that stuff out. What's expensive, what isn't? If you build model cars, you want to build a Ferrari, it's going to be the most you ever spent. You want to drive a car? This is the cheapest you can do with a new car. We all get that. What happens in healthcare? So a lot of you may be aware of the enormous controversy lately over these high-priced drugs. And by the way, I'm not going to defend the price of anything in healthcare, right? All of it is set by non-market means. But what's interesting about $84,000 for Sovaldi is that the manufacturer of Sovaldi was willing to do a guaranteed cure basis for pricing. We cure your hep C or you don't pay, and the insurers and Medicare couldn't figure out how to do it. Didn't want to do it. I'll take questions after if that's all right. And everybody's screaming about how extraordinarily expensive $84,000 is. step back. So the average person gets 1 to 2 things that could kill them over a lifetime. Sovaldi's targeted. So that $84,000 we can think about as $84,000 per cure. The average amount we spend or expect to spend on healthcare over a person's lifetime, I'm doing rough numbers here, roughly $800,000 per person per life. Which means curing one of the 1 or 2 things you're going to get that could kill you over your life costs 10% of your healthcare budget. Now, when you think of Sovaldi that way, does it seem expensive, or does the other 90% seem expensive? When healthcare sold to us, it's sold as this: saving things that could kill us. But what's interesting is, if you look at this stuff, is that's not actually where the money goes. The money goes to all of the above. What's interesting about this economy is that Sovaldi is actually cheaper on a per life saved basis than statins. But statins cost a couple $100 a year now. And so from the healthcare's point of view, like the Ferrari, the model Ferrari, they're cheaper. But by the point of view of how we do value everywhere else, they're more expensive. Why does this matter? Here's why it matters. The way an economy is supposed to work, the way the computer and mobile telephone economy have worked, the way almost everything works, is that over time, things that create more value get more of the dollar. That's how you drive change. In 1960, before Medicare, prescription drugs took about 9.7 cents out of every healthcare dollar spent. Hospitals took 32.7%. Fast forward 56 years later. What's happened in the last 56 years? Hospitals have lost half of their inpatient business, which was almost all of their business in 1960. And drugs have contributed, prescription drugs have contributed far more to care than they did in 1960. They're a major part of oncology, a major part of end of life, an enormous reason why surgery can be less invasive, et cetera, et cetera, et cetera. There's no question that the last 55 years, and in preventive care, they are the bulk of preventive care spending, or at least of value. So we would expect to see meaningful shifts. I mean, if you saw the percent of telephone dollars spent on landlines versus mobile lines in 1960 versus today, these would be very different, right? This is a number in 2014. Prescription drugs take 9.8% of our healthcare spending, and hospitals take 32.1%, and that is Soviet. It's what it is. It's not markets. It's not about technology. It's not about value. The dollars are following what they always did, because whether we like it or not, with the power of very large insurers, very large government agencies, the value is going to be apportioned according to power and past practice, not future and benefit. I would argue this is a major threat to our health, because those things coming down the line that can make the biggest difference in health may not fit well into these categories. That handsome young man is Kenneth Arrow, a Nobel Prize winner in economics and a very brilliant man, who argued 51 years ago that healthcare could never be like other industries because the seller, i.e. you guys, had so much of an information advantage over the buyer, your patients, that the buyer would buy anything you told him to. In fact, you could use the ultimate advertising technique of telling the buyer he would die unless he bought what you were selling him. These are in economics terms. Information asymmetry is the fancy name for it. And Arrow was right 51 years ago. But a lot has changed in 51 years. The biggest change, obviously, is the internet, and the fact that I suspect many of you have patients who know a lot more about healthcare than you do. But even beyond that ability of a patient to educate themselves, the ability of individual consumers to understand everything about markets they enter, or far more importantly, benefit from those who do, has expanded and transformed every other industry except for healthcare. And we know what consumers want, right? They want ease of use, they want to be remembered, they want to own their records, they want to buy things easily. None of these things are true in healthcare. And they're not true because Arrow was right 51 years ago, and people quote him today right? People talk about the National Health Service in Britain as if that's what we should do here as opposed to what it is, which is a 70-year-old idea in an economy that has embraced no other 70-year-old ideas. These are ancient ideas and ancient conventional wisdom that's just no longer right. What's interesting is that for all the changes in the economy that have occurred during this time that the healthcare industry hasn't updated itself for, the changes in healthcare have even been greater. Because Arrow and his ilk were writing at a time where most healthcare was urgent, major, and you did what the doctor said. How many of you practiced medicine that day? How many of your patients reflect this reality, which is that almost all of the conditions that were urgent are a tiny percent of the practice. And the bulk of what we deal with are chronic conditions, long-term issues. I had my college intern do this, and I still don't really understand it, but apparently, so I'll tell you what it is. It looks at hospital admissions over a 20-year period. And what you'll see is almost all the things we used to say, I got to get you on the table tomorrow for, are gone. Is it possible to go back one? Yeah, it's perfect. What I'm trying to say is it's a blank canvas. We can, but if you look at this side, what's interesting is that over the 20 years, for our highest priced care, which is hospital care, almost all of the things that we used to think of as urgent and major, like your house burning down, or as the people who hate consumer-driven care always say, hey, who wants to shop around when you have a heart attack? It's not that people don't have heart attacks. It's that right now that's like saying the tire market should be based on someone who has a blowout on a highway. It's the smallest part of our spending. And what's interesting in the way people practice care today, and consumers, patients, if you will, consume care, is that almost everything involves a decision by the patient. A decision made in consultation with a doctor. But the sort of car mechanic model of healthcare, which is, you know, you got to bust at this, here's how I'm going to fix it, describes very little of medicine today. And what's interesting is in that opportunity for a patient choice, in fact, the requirement of a patient choice, is the possibility to completely transform how we think about and organize the provision of healthcare, right? Kenneth Arrow said, I walk into a doctor and the doctor says, do this now or you'll die. So we need somebody between me and the doctor to discipline that. So 51 years later of that not working, we face a very different reality, which is that chances are your doctor says, I'm concerned about diabetes or hypertension, or even you have cancer. Let's talk about your options. So forget what the politicians say. This is an industry in which consumer choice is not only possible, but baked into the way care is practiced today. What's missing is the rest of the apparatus, service, quality, efficiency, that's driven in every other industry, because we're not the customer. So, what's new? I stand before you as a massive optimist, but you wouldn't know it from anything I've said so far. Let me tell you why I'm an optimist. A few years ago in the Affordable Care Act was included a Cadillac tax that forced companies to think about, particularly the ones with the greatest healthcare benefits, how they were going to control benefits, how they were going to control inflation in health insurance, even though many of us believe that the Affordable Care Act would reignite healthcare inflation. How do you do both? Well, the answer has been a massive acceleration in high deductible insurance. And even with the Cadillac tax having now been repealed, that acceleration is continuing rapidly. In fact, the National Business Group on Health just published yesterday some new statistics. 51% of American employees now have a deductible, single employees, so this is not family, now have a deductible in excess of $1,000. The average deductible for a single employee is almost $1,500. Those numbers have grown by 49% since 2010. Deductibles themselves are up 67% among corporate payers, and on the exchanges, although we don't have complete data, it looks like 90% of those who have bought exchange plans have a high deductible. Now, for those of us or for those of you who read my book, for those of us, we'll see I favored high deductibles as well. This isn't necessarily the development we wanted. So what we hoped is that high deductible accounts would have premiums that were so much lower that you could put the savings in health savings accounts and really start to build up a nest egg of health savings against true disaster. Because the Affordable Care Act meaningfully expanded the comprehensiveness of insurance, most of that savings has actually gone into expanded benefits. Nevertheless, the number of people with health savings accounts is growing rapidly. Roughly 30% of employees with high deductibles have health savings accounts. That's up meaningfully in the last year. My own company, and I suspect other companies that are high benefit companies, pushing everyone into high deductible accounts and massively subsidizing their HSAs. We do it on a 2-to-1 basis because the economics are so terrific for us and we make it for the employee. But I think high deductibles have been understood in the context of traditional healthcare policy, which is, they'll get consumers to shop around, but really what they'll do is they'll defer needed care and healthcare will be even less affordable. So that is happening, and I think that's a real risk. However, something else is happening. Remember that chart about the concentration of healthcare spending? A typical family in a year, no one gets really sick, spends $1,000, $1,500, sometimes $2,000 on healthcare. With high deductible plans, almost all of that is going to come out of pocket. Now, the first year that happens, you curse your employer or your insurer or both. Maybe you do the second year as well. But at some point, you start to think about healthcare the way you think about everything else, which is, I pay for it. I know the problem of bad debts among physicians and hospitals has grown during that transition because a patient walks in and says, do you take my insurance? And the physician in the hospital says, sure, and later bills you for the deductible, and you say, but you took my insurance. But that's transitional. What's the long-term impact of having these deductibles for a family that's $2,500 or $5,000? At some point, you start thinking of yourself who's got, like, homeowners insurance. If something goes really bad, I'll use it. But most years, I got to figure out arrangements myself. And the great thing is, particularly when I think about the goals of so many of the people here, is for the first time since 1965, we actually have fertile soil for new ideas in healthcare because we have a new customer. The last 2.5 generations have been about growing customer power of insurers, CMS, state Medicaid agencies, and other large bureaucracies. We have started to unleash, it looks like 45 million people, a number that's growing very, very rapidly, a class of people who sometimes very soon are going to say to themselves, I buy healthcare out of pocket, unless things get really bad. That's also what I do with my furniture and my gas fill-ups. And that change in mentality actually gives you and all the others trying to do something new in healthcare somebody to talk to. One of the things misunderstood about consumerism in healthcare, and again, it's because of this island of healthcare in which people have a hard time taking in lessons from outside, is that consumerism means consumers have to do a lot of work. They got to shop around. Well, those of you who are trying to create different models of care know it's the opposite. The burden in consumer-driven anything is on the seller. There's a tiny percentage of us who shop around, and most of it do it only for 1 or 2 products we really love. Walmart spends a couple $2 billion a year telling people they have the lowest prices. because most people don't walk into the store and compare. You got to be told. And then, of course, you got to do it. And that is the biggest change in incentives from having this new class of customers, is because they're like the little old lady in the supermarket. You've got to reach out to them. Not like today. Those of you who are patients as well as physicians know there is no harder work than being a beneficiary of insurance in healthcare. I want to close with one other idea that I think is very hard for people to get their arms around in healthcare. So healthcare is our biggest industry. And we have this hope that a human activity involving 18 million suppliers and 315 million customers can be controlled, can be organized. And what we're left with is that chart I showed you about prescription drugs and hospitals, which is we're left with this. Let's keep it flat. Let's discourage innovation. Let everybody take their share. We've retarded our own progress in that sense. We want, in healthcare, someone to protect us, someone to make us feel better. It's a big part of the reason we and others around the world have created structures to protect us against expenses that cost far more than the expenses would have cost. It's a tiny fraction of people who ever could spend on healthcare costs what Becky and every single member of her generation who's working will put into the system. We want to think healthcare can be organized with some controlling force that protects us against cost, assures quality, safety, service, and drives innovation. It's not possible. Not for something this complicated. I've talked a lot about the benefit of markets and competition in healthcare. There's an enormous benefit for government in healthcare. But I ask you to consider, will government be better at regulating safety, quality, and appropriateness as a partner, as it is today, or as a regulator, as is in other industries? Contrast what government does in the airline industry to what government does in the healthcare industry. I want to come back to that in a second. But the reality is, in most industries, we less look for a Clint Eastwood model than we do, obviously, for the brilliant Blazing Saddles model, in which Cleveland Little, at one point, took himself hostage. The reality is the way the most organized things work is through improvisation, experimentation, competition. And the top-down control of something this complex has not just failed, but it's failed to do what it says it's going to do. Protect us from inflation, inappropriate care, and unsafe care. And that gets to why I'm here. It's a picture of my dad and my 15-year-old son. I'm not sure he was 15 when this picture was taken. It does feel like yesterday. I know all of you know that feeling. My dad was feeling some shortness of breath after work and went to a hospital where he was kept in observation. And through a series of accidents, acquired an infection in 24 hours that killed him 5 weeks later. He never left the hospital. You know, when after having gone through that, and if you've ever been through that with a loved one, well, maybe less for you all because you see it, although my sister's a physician, the extraordinary disorganization, lack of navigability of our hospital system for a patient facing something serious and ultimately life-threatening, that was the mistake of the system itself, is mind-boggling in this day and age. Mind-boggling. You know, our physician said, it would really be best if someone was with your father at all times from the family. And in fact, twice we had someone come to take him for a procedure meant for other patients. Lord knows what else they did to him. I've always said, can you imagine if FedEx said, we'll get your package there, but it would be best if someone was with it at all times? How do we accept these things? How is this possible today? A month after my dad died, Atul Gawande published a piece in the New Yorker. At one point, Atul said to me if he knew I would write my book as a result, he never would have published this piece, in which he talked about how a couple of doctors, a couple associated now with the Leapfrog group, of which I'm a board member, had come up with a series of protocols that meaningfully reduced, the number of deaths in hospitals from acquired infections. 2/3, 3/4 in places have been tried, was having an impossible time getting hospitals to do it, and the cost was relatively minor. It was fundamentally cultural. And I was still going through grief over what happened to my father, and it set off an alarm in me. One, the number of 100,000 deaths a year, something I had no idea. It's an unbelievable number, and many of you may have seen Marty Macri's recent Hopkins study that said all of the accidental deaths from the healthcare system now make it the third leading cause of death in the United States. But it's astonishing if you're outside the system to think about that. But something was even more incredible to me. I ran a movie theater chain at one point in a very checkered career. And we had a rule. Soda spills, it's got to be cleaned up in 15 minutes, or we actually penalize the manager on duty. The reason wasn't liability. The reason is that our biggest business is Saturday night. And Saturday night is date night, which means you got a lot of young couples who don't have a lot of money, who hired a sitter, or going to a movie. They see a soda spill. It feels like less of a big night for them. Will lose their business. It was relatively easy to implement. No one died from the soda spills. And a businessman, I thought, how on earth is it possible that we could do that in a movie theater chain, a secondary movie theater chain none of you have ever heard of, and hospitals can't, or more importantly, won't do it. It's not worth it. And it's not worth it not because anyone in a hospital doesn't care about accidental death, but because compared to the other priorities, it's got to be lower. Remember that bill handed to my mother. $636,000, someone paid some fraction of it, Medicare did, obviously, and the hospital got paid. Imagine if they had to present that bill to my mother. Pretend that Medicare gave my mother the $70,000 they paid and said, you're the customer, your money. You want to try to collect that as a hospital? You want to talk to my mother and say, we killed your husband, but we did run up a bit of a bill doing it. What's that conversation like? Well, we know those conversations. We have them all throughout the rest of the economy. We need to have them in healthcare. Because you don't need to be evil to make these mistakes in healthcare. You just need to not have the little old ladies running around and saying irrational things that force you to be better. Because otherwise you'll go across the street. And the great thing about high deductible plans is for a meaningful number of Americans, they're going to start looking for someplace across the street if we don't get it right. At the end of the day, we talk a lot about the big picture in healthcare. But what really matters, what always matters, is the small picture. We have 315 million people who have stories about dysfunction in our most important industry. High prices, lost records, lack of coordination, poor information, no follow-through, all the way up to error and death. It's the little picture that's going to drive change in healthcare. And that's why I come optimistic, because suddenly in healthcare, for the first time in a while, people with new ideas, like the ones that you're embracing, have someone to talk to. Thanks very much.
Time for a couple of questions, and then if you want book signing, then David will be more than happy to stay for a little while and do so. Chad?
Just a quick thing. First of all, hearing the lecture today does not get everybody out of reading the book. Okay, the book is fantastic. A quick question, and perhaps I'm getting this statistic wrong, but if I'm remembering correctly, in your book you said prior to 1965, the average senior citizen spent about 10% of their income on medical care, but now with Medicare, it's 20% of their income. Is that correct? And where did you get that statistic from?
Well, I made it up, but it's it's important nevertheless. I mean, it actually was fairly hard to find, and I'd have to. I thought I had footnoted that, but if not, I actually will send to you. There was a survey that. Now, I can't remember this RRP or CMS did. It's been a while, but I'd have to go look at the source there. They are two different sources. So the census used to look at this, and the census did look at this pre-Medicare. I don't believe there's census data on it anymore. But I think people argue about, like even if you talk to RRP, which I did about those numbers, their numbers aren't quite as extreme, but they certainly agree with the general point. And it's a really important one. I'm glad you brought it up, because it's the Beckyization of everybody. So lots of people believe, okay, well, that's true for people who are working, but you got to have Medicare, right? So it's almost certain that it is certain that seniors before Medicare paid a lower percent of their income on health care when they were paying, in those days, somewhere about 70% of their health care bill. Some kept insurance after work, than they are today when they're paying 5%. So in other words, the inflation in cost has been so great that paying 5% of your care today costs more than 70. It's not just an interesting number. It explains why we're at where we're at, right? So Becky's a real person, and when I sat down and showed her this, she was stunned. Right? She's a kid earning $30,000 a year, and as far as she's concerned, she doesn't use a lot of health care because she goes to the doctor once or twice a year. The same thing has happened with our seniors. Seniors can't imagine living without Medicare, and they don't realize how much it costs them, not just in terms of money, right? So you probably know that Medicare premiums are now a meaningful percent of the Social Security benefit. And there's talk about capping them vis-a-vis the Social Security benefit, when before they were almost irrelevant. The fact is, the incentives for inflation in the system, or the lack of disincentives, are so great, in part because people don't directly bear that we all have caused ourselves, I mean, if you're working, 20 to 25% of your income goes to the healthcare system. If you don't know that, what else do you spend 20 to 25% that you don't know about? That's why it's happened, right? And so that everybody supports the system that's taking more and more money out of their pockets without knowing it. And I think that's what makes that, I think it's 2 to 1. RRP says it's 1.5 to 1. Whatever it is, it's a lot more than they were spending in 1965.
Thank you so much.
Hi, Eric Madrid. I'm a family physician in Chesapeake, Virginia. I'm dying to know, in your pie graphs where you showed 32% of healthcare dollars go to hospital care, 10% go to drugs, and the rest of the pie was blank. How does that change between 1960 and 2010, I guess it was?
So there's remarkable stability, except in 2 areas, 3 areas really. The biggest decline, not a surprise to many of you, is in the category called professional services, which is mostly seeing doctors. It's not a gigantic decline. It's about 3 or 4 percentage points of the share. The biggest increase has been in the categories known as home medical care and administration. So obviously, 1960 was pre-Medicare, Medicaid. There was very little government administration, and insurance administration was so little. Now administration itself has taken 10% off the top. That's a meaningful number.
Over there.
Twyla Bray, Citizens Council for Health Freedom, and founder of the Wedge of Health Freedom. And I'm also a nurse. And I find it interesting, your comment about somebody having to be in the hospital with people. I will just say that somebody in Washington, D.C. told me she was in the hospital for a week, and the nurses, she saw lots of nurses, but they'd just come into her room. They would enter data and they'd leave, and they wouldn't even ask her how she was doing. So I think that's a great concern. With Medicare, do you have any sense when you give your presentation to folks who are 65 and over or about to be there, if they would be willing to leave Medicare?
No, they're not. And that's really important. I'm glad you asked that. So one of the problems, I think, with people who try to reform healthcare is they think of it from a government perspective. So the first thing you look at is, how do I reform Medicare? So the last thing I would do is reform Medicare. When you look at disruption in the rest of our economy, what happens is someone introduces a new model that works for some share of the people, and that share grows. So Uber starts as a place for, 20-somethings to go out, get drunk, and still get home safe. Ultimately, it hits everybody. right? Facebook starts out as something for for Harvard students and then college students. Ultimately, it hits everybody. Unfortunately, in healthcare policy, I can't tell you the number of times I hear, but what about a retired woman with a disability in a rural neighborhood in Kansas? Well, you know what? There is no reform in anything that works for 100% of the people. Let's focus on disruptive models, like I think you're trying to do here, that aim for some percentage of the population. There's only one way to solve Medicare, and that's to make seniors beg to get out of it. And the only way to get them to beg to get out of it is to produce a better healthcare economy outside of it. Nobody ever decided that the post office wasn't going to deliver emails, right? There was no law. We stopped using the post office because we all preferred emails, but we didn't start all preferring emails. And I think one of the things that so constricts healthcare reform discussion is it's got to work for everyone day one. It's got to solve the Medicare problem. We're never going to solve the Medicare problem until we create something better, because seniors have grown so dependent on the system of care that they're never going to voluntarily submit to something else unless that other thing is clearly better. And frankly, what we owe them is to create that better thing among privately insured, high-deductible patients, and then make them ask to get out. But they vote.
Last question.
Say
We're
one
running,
thing.
Twyla, we're running late, so can we just get the last question over here, please?
Okay, I just wanted to say that 201 doctors' patients are Medicare patients paying cash.
And in fact, in some markets, particularly Manhattan where I am, there is a meaningful number of physicians who don't take Medicare, who have meaningful senior practices where the seniors say, I would rather have a relationship with a doctor who's not taking Medicare because I'm concerned about how Medicare distorts that relationship. But I would say getting from 200 patients to 40 million is way too big a mountain unless there is something clearly better that Medicare is preventing them from getting into. I want to create that first, I think.
So how did we get here?
How did we get here?
Yeah.
Well, I mean, my point is that we got here through billions and billions of decisions, all of which involved how does a provider sector best serve its customer? And its customers, insurers, and government. And no matter how well-meaning, at the end of the day, an insurer and government doesn't care about what individuals care about. They're never going to be my grandmother with that carton of milk. They're never going to be my mother angry that the hospital killed my father. What they're going to be is a government bureaucracy that says, we don't want any hospitals to go out of business, so we'll penalize you 1 or 2% for killing his father. Well, that's a different conversation. It's a more rational conversation. So rational conversations are bad ones because we don't have those in the economy. We have the, you want me to pay what? For what? And you're giving me what? Those are the right conversations. We don't have them in healthcare. And there have to be billions of them. And what we hope is that there'll be one. There'll be Clint Eastwood saying, you'll pay this for this and this for this, and it'll be, and it's just hopeless. And it's gotten more hopeless. And the reason I start by comparing it to the mobile phone is that many of us are old enough to remember when this was unimaginable. You needed a PhD in computer science to work a computer. Those of us who took, programming in high school, it's inconceivable that 85-year-olds would be carrying this around, loving it and using it for everything. Well, it's not unregulated. I don't believe in a lack of regulation. I just believe in once the government is the customer, it can no longer be a good regulator. Government's not a customer of the airlines. I wrote this piece for Time in which I said, remember when Malaysian Air had those 2 accidents in 6 months? One was caused by the Russians shooting a plane down, and the other, we still don't know what happened. Imagine if Malaysian Air had said to its regulator, it's unfair to disclose our name to the public because these weren't our fault. Right? So why should we deal with the consequences? We do that in the hospital sector. There's tons of data that we don't disclose in theory to benefit the patient, but we all know that's not true. So that we can't do what we did to Malaysian Air. Stock collapsed and their customer base collapsed, and they had to work very hard to rebuild even though they didn't arm the Ukrainian rebels. And that's the point, right, is that's an irrational consumer response that makes an airline be even better than rationally it should be. because that's the only way to win customers. That power of that competitive need to serve disaggregated individuals drives everything on earth, except healthcare.
Well, again, I'd like to thank David Goldhill for being our lunchtime speaker. He did a wonderful job. Let's have a round of applause for him.
Thank you. Just one shameless plug. I know that many of you are very busy, and it was very kind of you to distribute books. My publisher, Random House, just put online, or I guess in Amazon, an essay of mine, which is a shorter version of the book with some thoughts about what the Affordable Care Act has meant and what high deductibles mean. It's another 99 cents, but it's also, for those of you who don't want to read the whole book, some of the ideas are in there and it's shorter, and it was just out, I think, this week. So anyway, thank you.
Well, great. Thank you again.